is a little different. We're actually going to be having questions throughout the entire presentation, and after each slide, there'll be opportunities to just type your questions in the chat box. Next slide there, I just wanted to show you a schedule of the upcoming sessions so you can know what to look forward to. Let's see, so starting next week in June, we're going to be moving to weekly instead of twice a week. And a very important topic about COVID tracking logs and checklists from the Hawaii Department of Health. We're going to talk a little bit more about COVID supports for the care homes and the other long-term services supports, and then home health programs coming up. Okay, so we will be offering CMEs. Nurses can use these for CE purposes, and we will be offering certificates of attendance to all participants who complete an evaluation. If you haven't registered, we encourage you to do so after this webinar. There are evaluations which can be found on our website under the evaluations tab or by following the link that will be posted in the chat box. At this time, we ask you to enter your name into the chat box for attendance purposes. And for those of you calling on the phone, if you can unmute yourself and tell us your name, we can write it down. Let me go see if there are people here, participants who are on telephone.
I need your phone.
A few people on the phone. Anybody want to unmute yourself and tell us who you are? Too shy?
Rosalani Playbook.
Okay.
Yes.
Anybody else? And some of you, okay. All right. So if you have a phone, just if you can put your name in there or let us know, or you'll just have to email us later. Okay. Anyway, so today we are going to be talking about COVID challenges and opportunities in assisted living. We have two very special speakers, Dr. Daniel Hamowitz. He is medical director of Arden Courts of Yardley Personal Care and the initial chair of AMDA's Assisted Living Work Group and Committee all the way from Pennsylvania. We also have Josh Allen, who is the principal at the Allen Flores Consulting Group. He's a registered nurse with over 25 years of experience in senior living, including executive leadership, where he has overseen health services, staff development, and regulatory compliance. A lot of experience in assisted living and the challenges and opportunities there. So I'm going to just open the floor now to our two special speakers and take it away. Thank you.
Hey, Dan, you're muted.
Oh, sorry. That wasn't my fault. So if we ever do a webinar again, I'll take the lead, Josh, and if we do one again, I'll let you take the lead on the next one. Is that okay?
Sure.
All right. Can we go back one slide for a sec?
I'm getting an echo. Is anyone else getting that?
Yeah. I don't know why that is. Should I put myself on mute again?
No, I think it's all better.
Okay. Is that better in the audience? I think that's better. Okay, John, could we go back a slide? Okay, so I'm calling this the Assisted Playbook because I'll tell you the story of how this came to be. And it's kind of, I'm hoping to give you a mindset or like a path to use that can kind of be consistent when you're dealing with COVID in assisted living. Next slide, please. Neither Josh and I have any disclosures. Next slide. So what we're going to do is we're going to talk about what happened to us, what we've seen in assisted living. And again, that's the point of the playbook. It's a framework for how you can work with your community as you go through. Hopefully, if you're lucky, you'll never get COVID in your facility. But basically what I want to try to do is to put everything you ever wanted to know about COVID in assisted living, but didn't know where to ask. We're going to do it all for you in an hour, right? So Josh,
yeah, sounds good.
We need to talk really fast. And one of the things that we're gonna really, and see, look at Dr. Wen, she's smiling. what we want to try to help you with is talk about some of the differences. There's a lot of similarities, obviously, between nursing homes and assisted living communities in COVID, but we will hopefully want to point out some of the differences. And Dr. Warner, we talked about our format. What I did was we're going to have 2 topics per slide. So when the topic comes up, when the slide comes up, if you have questions, start writing them right then and there. So we'll try to tackle like 2 topics per slide, and hopefully we'll get, we'll do the questions, the answers when it's right on your mind, and we can progress through. So that's what I sort of thought. I thought it was a good idea. Josh told me to do it, and I do what Josh tells me. Okay, next, please. Then they not may be entirely true. So our experience with COVID. Now, Josh, I'll tell mine first, and then this gives your experiences, which are terrific, I must say. But if you could also tell the audience maybe what you've seen, like maybe the variability, the difference between what you've seen in a lot of your the places where you consult. Okay, so I am the medical director at 3 different situations in assisted living. One of those is a freestanding memory loss unit, and it was dreadful. We had at least 90% COVID. It was like about 60 residents. I say it's a 40% death rate. It's about 50%. We're down to 30. So we went from 60 to 30. They had corporate, but not local leadership. So that was the one, and that was harrowing. And that's where I don't even want to talk about it. It's so upsetting. The second instance where I do medical direction assisted living is it's a nonprofit CCRC. It's under their corporate umbrella. And what they did is they had an outbreak at one of their assisted living units and none at the other. So what they did was they included me as part of their local leadership team, which I was pleased about. And you'd say, well, what, Dan, are you crazy? That is, we meet 3 times a week for our COVID response team, and each of the meetings is 2 to 3.5 hours. So I've spent hours and hours and hours on this. But the president of the company, I think, is a terrific guy, and he's into planning. And this is me by nature. I believe in planning. And Josh, I'll be curious to your opinion about this. I think planning can really help you if you have an outbreak. So the third assisted living that I was at is, it's also a CCRC, but they're not really connected. Well, they're actually not connected. It's a freestanding nursing home, a freestanding assisted living, and a freestanding independent living. So what happened is they didn't have any meetings or any leadership. So I said to myself, which I say to myself a lot, why don't I take the things that have happened at the first bullet point assisted living, take the kind of things we talk about at the second where I'm involved, and develop subjects. So I went to the executive director, the administrator, and the director of nursing, and I said, we need to meet twice a week at a minimum to start talking about things. Et voila, that was the genesis of the playbook. So I'm hoping that Josh and I can help you as we go through some of those things. Josh, what's your experience been?
Sure. So I'm a registered nurse. I have a certification in assisted living from the American Assisted Living Nurses Association. I've been in senior living for my entire nursing career, which goes back about 25 years now. I've known Dan for 20 of those years, which is, I think he's basically responsible for whether I'm a good nurse or not, is the way I like to think of it.
Well, that's very nice of you.
What we do is we provide clinical support to mostly for-profit, larger assisted living communities. Most of them are regional operators that aren't quite big enough to have a full clinical team. So they maybe have 1 or 2 nurses at a regional level, and then we work with them to do everything you would think of kind of a corporate nurse. We write policies and procedures, we respond to crises, we do training, we do audits, all the stuff you would expect. We work with about a little over 350 assisted living communities in 35 to 40 states. Out of those communities, we have had COVID in some form or fashion in about 80 communities. And that has ranged from, a number of examples have been just 1 or 2 staff members, that were tested positive because they failed a screening, or maybe they were exposed outside of work at another job, or family members, or what have you. The majority of our cases have not been as extreme as the first one that Dan mentioned. We've had a couple that have fallen into that type of spread, where we've had significant percentage of residents test positive, significant percentages of deaths. But I would say overwhelmingly, the cases have been more moderate, where we've had, 10 to 12 residents positive, maybe a similar number of staff positive. And overall, I think the management of them has been pretty effective. But I'm still struggle a little bit with how much of it is the luck of the draw, how much of it is based on what kind of testing has been done. Because in a lot of those communities where we've only had maybe 1 or 2 employees test positive, there hasn't always been widespread point prevalence testing. So we certainly could have a lot more cases we just didn't know about. It's also kind of interesting to me, and we'll jump into the playbook here, but it's interesting to me how we've kind of gone through these phases with COVID. It's kind of ironic, actually. When COVID first started blowing up in the US early March, I was actually on vacation in Hawaii with my entire family. And when we left, COVID was just starting to, really become a growing issue in the U.S. And then by the time we got home, states were shutting down, and it was full-blown COVID protocols. So it's been an interesting roller coaster since then. In the early days, you think like early to mid-March, it was all about PPE. Where can we get it? What do we do if we don't have it? People literally buying rain jackets instead of gowns, reusing of masks, all of that stuff, which hasn't gone away entirely. Obviously, there still are PPE struggles. Then we moved into obviously just responding to active cases in communities. How do we deal with that? For a long time there, the most common question I got was figuring out when employees could come back to work. They've been exposed, they've tested positive, they've had symptoms. When can they come back to work? And if I had $1 for every time I've regurgitated the CDC return to work criteria, I'd be retired by now. Then more recently, it's sort of transitioned to, in my world, 2 big questions. Number 1 is testing. Who do we test? When do we test? When do we retest? What kind of test? And now, in many states where we operate, we're looking at reopening. We have communities in places like Texas, Missouri, Tennessee, even now California, which are in various stages of reopening, and we're dealing with those challenges. So, we've kind of seen the good, the bad, and the ugly so far of COVID. So I'm interested to talk more about it with you guys tonight.
Well, thank you, Josh. I think the main question I have is, why didn't you invite me to vacation on Hawaii? is what you didn't tell me. So thanks a lot, Buster. But what I've seen in next time is how COVID has changed is, if you think about it, at first the whole focus was on hospitals, all these stories about hospitals getting overwhelmed. Then as it began to creep into the public's consciousness, it was nursing homes, because I guess of what happened in Washington. But now, what I think those of us in the know, here, are that the most endangered place is probably assisted living. Like at the CCRC, where we have all the COVID response team with all our meetings, we focused on keeping out of the nursing home. And where was our first case? In assisted living. So I do think that if anything's going to change with this, and hopefully we'll have some optimistic notes by the end, maybe there is some kind of change, or the realization that maybe we could do better in assisted living. So that being said, let's go to the first slide, the next slide, first playbook slide, and there it is. Now, this is just to give you a heads up. This is the list of all the things, and I'm not going to read them off because I am making the assumption everybody can read. You're going to have time for every single one of these because we're going to go through all of these. So if there's a particular one here that you have a question on it and you don't have questions previously, get your typing ready in the chat box. But these are all the things we're going to talk about. So next, please. So let's start about the leadership team and sending residents home. But by the way, I was talking to Paul Katz, who is the head of AMDA's personal care, assisted living meeting. They call it personal care in Pennsylvania if I slip up. And I think part of the reason that it's been so bad in assisted living is because, it's bad in nursing homes, but assisted living, you could argue, are basically nursing homes without nurses. That's where the problem has become. And, if you look at the variety of assisted living, there's differences in leadership. Look at my examples. You have a national corporate, you have a statewide corporate, you have a local one. There are differences in this, but I think one of the things I found in assisted living is that we can be all together, but everybody's alone at the same time. Mm-hmm. So I think that even if you have, corporate leadership who's going to meet with you once a week, I think there's advantages of the local leadership team. Now, part of the issue in assisted living around the country is that there's no mandate because of the regs, as opposed to nursing homes. There's no medical director. And I think this is an opportunity where if you want to have somebody lead, a lot of times in these situations, it's good to have a healthcare professional be the leader, and it could be the de facto medical director tends to be the doctor who has the most patients in the facility, but it could be a community physician. It could be an NP. It could be a PA. Maybe it's the administrator. Whoever it is, there is an opportunity for making somebody an interim medical director. But I do think what's important is that leadership leads. And I'm a strong advocate of this, that you really want to have people step up to the plate and have an organized way of going through things, like the Playbook, for example, and go through this each and every time. Because, this evolves week by week. So before we get to sending residents home, Josh, do you want any comments you have about leadership assisted living?
I agree with, I always agree with Dan, but I agree.
Yeah, and I always agree with Josh.
But I think, one of the things I've seen, because most of the communities I work with do have some sort of corporate structure. What I've seen work well is when the corporate team is primarily focused on two things. One is setting policy and direction, so it's a lot of the stuff that now has become old hat to all of us, but just the COVID policies, droplet and contact precautions, when can people return to work, what sort of testing needs to be done, just the basics. Basically weeding through the CDC stuff so that the communities don't have to do it. Someone at corporate can take the time to go through the CDC's constant updates and changes, and that way someone at the community level isn't having to make sense of all that. It's also gotten a lot better now where the CDC and many of the health departments are putting out stuff specific to assisted living, whereas in the beginning it was long-term care, and we were trying to figure out, well, do they mean us, or do they mean nursing homes, or do they mean both, or how do we fit in? The other big thing I think helps from a corporate standpoint is procurement of resources. So whether that's accessing PPE, dealing with pay issues, if you're going to do any kind of hero pay or what have you, to keep staff coming to the community, letting the corporate leadership focus on those issues. But I really believe very strongly that at the end of the day, similar to what Dan said, it's going to be the leader in the community that will make or break the COVID response. And they don't, it certainly helps when they are a clinician or have access to a clinician, as Dan talked about, but really they need to be calm and they need to be organized. I've been on calls. We're just trying to figure out a community's line list. Takes 45 minutes, who's had COVID and who hasn't. And so just being organized and setting that tone for the rest of the staff in the community, because as I'm sure many of you on the webinar have dealt with COVID in your communities or in your practice, staff start running for the hills. We find that pretty consistently in the early days of a COVID case. They'll stop coming to work. They'll just up and quit. They often
you're getting into the staffing thing. Hold off on that.
Sorry. Okay.
That's okay.
I think the medical director point is a really interesting one because, you know, in assisted living, it's obviously still, you know, I think relatively uncommon for communities to have a true designated medical director, but I know Dan and I have been working just this week with a number of the communities I work with to set up some interim medical directorship, you know, partly for clinical decision making and even for simple things like having access to testing where you need it.
I have to say that Josh is amazing. Josh, you're amazing. And I think I speak for all of us because you are. You know, firstly, when he says about, you know, the people don't know who assisted living is, you know, that's true. You know, the joke is that, of course, and you guys know this, the people who don't know who assisted living is the emergency room, because they just think, you know, assisted living is the same thing as a nursing home. You know, anything that's not a home is a nursing home. But let me tell you, the doctors, many doctors do not know the difference. And we'll talk about this later on too, but I've heard some very prominent senators of these countries, very famous people who you all know, I'm not going to name names, who have no idea what assisted living is. So there you have it. Mm-hmm. Now, again, to Josh's point, I really love the motto from the California Long-Term Care Medicine, California's AMDA affiliate. Their motto is be calm, be prepared, be informed. And I think that's a terrific way, because Josh, I think you said it very well. The staff takes its tone from the leadership team. And you can also volunteer to be a leader. Like I went on this call with the corporate medical director who, for one of my assisted livings I go to. And he's like, Dan, what are you doing on the call? And I'm like, because I want to be on the call. And he goes, you're the only medical director of our, you know, of our corporation, the only local one who's been on the calls. And I wear that as a badge of pride. And I think it's a way to step up to the plate to be a leader. And I, of course, encourage you all to do that. So while we're waiting for questions about leadership, if there are any, Josh, why don't you start off with the topic of taking residents home and having them come back, if you're okay with that.
This has been an interesting one. You know, and it's actually, we're starting to hear more of this now as the stay at home or the quarantine or whatever you want to call it, as it drags on. And, you know, for most of us, our residents have now been, you know, essentially limited to their apartments or close to it for 2.5 months. And we're seeing the really significant impacts of that on resident health, both from a physical standpoint. We've seen more falls, more wounds, more medication errors. And obviously from a psychological standpoint, psychosocial standpoint of isolation and depression. In at least 2 of the communities I work with, there have been suicides where the resident left a suicide note that directly referred to the COVID lockdown and the desire to no longer live in that environment. We've certainly had families now saying, you know what, I can't do this to my mom or my dad any longer. I'm just going to bring them home. At one point, the LA county health officer actually made a public statement in I think it was the LA Times or something, that said, you know, families of assisted living should think of taking their loved ones home. I understand the sentiment. I would just, our answer to that is, number one, forget COVID for a second. You've got to keep in mind there's a reason your loved one lives in this community in the first place, and overwhelmingly that's because they need some sort of support, whether that's medication management or assistance with ADLs, memory care issues with supervision and security. There's a reason you moved in here. And so if you're planning to take your loved one home, you have to really ask yourself if that is something you can actually manage. So if
right.
they're receiving med management, who's going to do that? If they wander and have you know, elopement issues, how are you going to manage that? So that's the first thing I think we have to wade through. The second question is, what's going to happen when they come back? This varies wildly by community, but most communities have some sort of quarantine protocol for when people move in or return. So you went home to get away from it, but then when you come back, you're right back in it. I feel like we're starting to see the light at the end of the tunnel with this, again, as more and more states move into some form of reopening. Many states are now exploring how to allow visitors to come back in to assisted living. And, you know, we all know that carries some COVID risk with it, but honestly, I'm on the side of the fence that says we've got to do it in a way that is safe, because what we're doing to our residents is just it's not sustainable.
Yeah, thank you, Josh. I think we're probably going to, do we have a 1 hour cutoff on this, Dr. Wen? Because we're not going to get through all this. So we'll accelerate a little bit, but just to a couple things. If you're going to develop the leadership team and if you're going to have residents go home, it's probably a good idea to try to do it soon, you know, before an outbreak. So do we have any questions on these two topics, Dr. Wen?
Not yet.
Okay. Well, that makes things quicker.
On.
Next slide. So now we're on staff and staff education. Now, again, I told you I made these slides. So I was looking for a picture of the assisted living staff. So I don't know. I've never been to an assisted living facility. So I don't know if this is what they look like, Dr. Wen. That was my joke. Did you like that? All right. So Josh, you were talking. you were mentioning this. So as we know, what happens when the staff, either they get a COVID case or they think there might be a COVID case? What does the staff do?
Yeah, they go running. I should actually back up and say the overwhelming majority don't. You know, the overwhelming majority stay, and I think they're under-recognized. I know everyone's talking about heroes, and most people think of doctors and nurses in scrubs standing in an emergency room, but there are many, many caregivers who, let's face it, we all know they're underpaid. It is what it is. You know, they're sticking through some, you know, real challenging COVID stuff. But generally speaking, you'll still have enough of them that do panic and run for the hills that it creates a staffing crisis. I mean, almost universally. So I think to the point, the first bullet here, having true disaster planning, meaning the plan can't just be, we'll figure it out. Like, you need to have a real plan. So none of this is rocket science. You know, do you have staffing agencies you can turn to? And have you lined them up? Have you asked if those staffing agencies will work in COVID positive buildings? Because some of them won't. Have you looked at doing alternative shifts? I know most buildings I've worked with that have had significant COVID outbreaks have gone to 12-hour shifts. And, you know, I don't know the labor laws of Hawaii, but I'm sure that brings all kinds of overtime pay and stuff you've got to work through. But it's amazing how much easier it is to figure out staffing when it's just 2 shifts of staff per day instead of 3. Obviously, dedicating staff to work with your COVID positive residents. We have had, in at least a handful of communities, we have had to do crisis staffing where we've taken COVID positive staff who are asymptomatic to work in COVID cohort units. That's obviously something you do as a last resort, but we've had to do that on a number of occasions. We've also, in some of this stuff, you know, it seems so common sense, but people, when they're panicking, don't think about it. Little things like, make sure when you go in the apartment, you do everything you can in as few visits as possible. So little things like the person dropping off the dinner tray can take the temperature, and that's one less visit into the apartment. You know, little things like that cut down on staffing and also cut down on PPE burn, which I know we'll get to later.
Right.
Probably and the last thing I would mention that has been surprisingly effective, it kind of goes back to Dan's point on leadership. The executive director or administrator, whoever's in charge of that assisted living community, should take the time to speak with each staff person individually. And I know that's hard to do, but doing that, we have found, is very powerful in making people feel comfortable. Very often they have simple questions. What happens if I get sick? Are we going to get tested? Do we have enough masks? You know, they have simple questions, but they're afraid to ask them. And since they don't ask them, they just stop coming to work. But if the leader takes the time to go face to face, and obviously with your masks on and socially distance, of course, but takes the time to meet with them and say, hey, you know, I know we have a COVID resident. I know you're worried. What are your questions? And just give each one of them a chance to do that. We have found that has been, it's a simple trick that actually one of our EDs mentioned to me, and it's been really, really effective at addressing staffing.
I completely agree with those. and you know, the education things are typical to those in a nursing facility, but I think it would be good for the administrator, or if you have a physician or a healthcare professional or the medical director, to talk to staff to try to have them stop panicking. Like what I tell them is, you know, it's not like COVID is Ebola. You know, the thing is that, yeah, you don't want to get it. If you get it, you're going to be sick, right? But the people who die, I'm just being really honest with you, the people who die are the residents, not the staff. I mean, you know, you read in the paper the odd, you know, the occasional 20-year-old, but they're not the people who are going to die, number one. And number two, their odds of getting COVID go way, way, way down if they're using PPE correctly. So I think that you want leadership to, it's the calm bit, you know, don't panic. It's not like you're going to see tons of nursing staff or aides just dropping off right and left. No, it's our residents.
Well, and you
So,
don't, to that point, you don't obviously want to sugarcoat it, but I like to remind people that, and this number has changed over the weeks, but as of right now, 94% of Americans with COVID-19 are alive.
Right.
You know, you
Right.
hear the number, which as of today crossed over 100,000 deaths, and that's obviously tragic. And I'm not trying to say it's not serious, but the overwhelming majority of people with COVID in the U.S. are alive and recovering, and staff often don't think of it that way.
Right. Dr. Wen, do we have any questions? No questions. Is it a shy group? You know, I just talked to the audience. If at least one of you could put in a question before the end, it would make Josh feel validated, right, Josh? It's all for Josh.
That's
Next
right.
slide,
All about
please.
the ego.
It is. It is. Okay. So housekeeping. You know, you think, well, why is housekeeping so high on the list here? And you know, my experiences with this have been staff. You've had problems, but almost every place I've been to has had trouble with housekeeping. When we had our outbreak, they had no housekeepers. They had to wind up going to an agency. It was early in the outbreak, so they could get agency, and they wound up paying exorbitant prices for them for like 2 weeks. I mean, they paid the housekeepers more than I make, I think. I was actually asking if I could get in on that, but as you can tell by the picture, I'm not very strong. But that's what you got to look at. You got to really focus on that. You know, when is housekeeping could be possibly more important when you want to do good infection prevention techniques. So I'm just telling you, housekeeping is super important. I don't know if we need to go through all. Why don't you talk a little bit about testing? I think, to me, Josh, it's not so much. There's not a huge difference, I think, between the testing, the testing questions in assisted living versus nursing homes.
Yeah, I think
if people have questions, go ahead. Go ahead, Josh.
I think they're essentially the same issues. Testing is without a doubt the biggest question. The biggest discussion point I have with our communities right now is, you're obviously hearing more and more states around the country are going to some form of mandatory testing. What I will say, though, and having worked in most of those states, a lot of them are claiming they're going to mandatory testing, but have yet to actually execute it. A lot of people are talking about it. We're going to test once a month, twice a month. We're going to test every nursing home resident, every assisted living resident. But very few states have actually pulled it off.
Yeah. Actually, so I'm just going to mention, because I don't want to spend a lot of time on this. Actually, next week's session or in a couple of weeks, we are going to have a whole session dedicated on testing.
Okay, good.
Yeah.
But we do have questions. We have two questions.
Yeah,
we have questions.
Things change by the time. Go ahead, Dr. Wayne. Tell us.
So what education programs did you provide for the residents of the assisted living facility?
I'm sorry, say that again. Go ahead, Josh.
Education of the residents of the
residents, right.
We have offered, I'll be honest, it hasn't been a lot of structured education for residents. We have done, I think, two things. One is many of our communities are doing regular Zoom meetings that both residents and family members are invited to. And frankly, you get more family members than you do residents, but we've found that to be very effective just to keep the communication open. And it's not so much formal education as it is just an update. Here's what's going on in the community, if they have or have not had COVID cases, and just keeping families apprised of what's going on. We've done a couple of formal education programs, again, most of them via webinar, and we just went through everything you would imagine. This was, honestly, it was earlier on in the pandemic, but it was, you know, kind of COVID 101, how is it transmitted, how is it prevented, the importance of hand washing, social distancing, and all, you know, all the things you could imagine in kind of a COVID basics.
Yeah, I haven't seen too much formal resident education either. It's trying to get them to adjust to the, you know, the new norm and make sure they realize what the implications are for them. But it more involves family, which we'll talk about. Go ahead, Dr. Nguyen. What other questions do we have?
Yeah, can you talk about how we can help staff to wear their PPE correctly without appearing to be nagging them?
We'll get to, yes, we'll get to that. That is so critical. What part of what is involved with the difficulties in assisted living is typically you get lesser trained staff, like you get unlicensed staff versus licensed CNAs. So you're going for probably a little lower of a an education basis. So one of the troubles with testing is that this has happened to me twice already. We've had somebody with the symptoms of COVID. They've had a test which was probably a false negative. So the staff just assumed that everything was great and they didn't have to worry about infection prevention anymore because the test was negative. I don't know if you've seen that, Josh. It's happened to me twice already. So, it's important to emphasize that. But we'll get to the PP question because that's really important. So any other questions on that?
Not on that. There's another question about examples of testing plans or policies that the facilities have been successful in implementing. Do you have examples?
Well, I think you're going to be talking about this in a couple of weeks, right?
Yes.
Testing plans, yeah. But I agree with Josh. I honestly think I'm already working at this plan with a couple homes, but I think this is going to fall by the wayside. I really do, because it was a political proclamation to say test everybody, and there are so many problems with it. I'm not saying don't test, but it needs to be more focused. Would you agree, Josh?
Yeah, I mean, I'll give you a very quick summary of the policy that we've been trying to encourage people to follow, and we've had success with. Number one is to obviously test folks who are symptomatic, residents or staff. We highly recommend that facilities have access to testing so that they don't have to rely on sending someone out, because that just varies wildly from city to city how well that works. So we recommend they connect with a lab. They'll need a doctor to obviously sign the lab requisition, a fine medical director like Dan, so that they have access to testing for anyone who is symptomatic, either residents or staff. And that has been a big benefit to catch cases early and obviously respond to them. Number two,
I'm sorry, Josh, go ahead.
Number two is most providers we work with, we are encouraging that they test move-ins or residents who are returning. Part of that is not only for good clinical practice, part of it, to be perfectly frank, is a little bit of optics and PR that families want to know you're testing new residents coming into the building. Beyond that, we do not recommend, I think to Dan's point, we do not recommend community-wide testing unless your health department tells you to. So that's generally, I think, for most of us, that's only if we have active cases. And even then, it's pretty hit and miss. Some health departments will want you to test, others won't. But I'm with Dan. I think the idea that we're going to test everyone to stop COVID, I don't think that's realistic.
Yeah, I agree. All right, let's go to the next. Go to the next slide.
One final comment, and then you go to the next slide. The comment is that Zoom is a good way of communication to educate with them about those that are not much tech people and no computer or telephone, or even internet at home, and they can do these with this new tech communication. So yeah,
we'll talk about Zoom when we talk about family education too.
Okay, great.
So thank you everybody for questions. Josh, go ahead, smile for the camera, Josh. See, look what you've done. You've made him happy. Cohorting and medical resources. One of the issues when they were pushing testing initially was, well, you got to test so you know how to cohort. And obviously, I haven't said this yet, the key thing in all of COVID for everybody is The one thing you want to do is make sure you keep COVID negative people negative. That is your ultimate goal of doing this. The trouble is that cohorting is much harder than people make it to be. You know, it's easier for politicians to say, well, you know, you get the lab, you find who's negative, you find who's positive, just go ahead and cohort. Go ahead, Josh, you talk about that.
It's profoundly difficult in an assisted living environment. For one thing, there's just simple logistics that, you know, compared to a nursing home, and even in nursing homes, this isn't always the case either, but an assisted living resident has crammed an entire life of belongings into a, you know, studio apartment. And so the idea that we're just going to simply move them down the hallway, no problem, it's just not that easy. Plus, most assisted livings don't have a wing of empty apartments. So you're displacing multiple people out of apartments. It's extremely difficult to do. It's not impossible. Where we've had success with cohorting has been mostly in two areas. One is memory care, because in most assisted livings, especially larger assisted livings, memory care is kind of a smaller unit, and so it's physically already separated. The second is you know, there's a number of ALs around the country that are set up as cottages. So instead of a big building of 100 apartments, you have little clusters of maybe 5 to 10 apartments. And in those cases, we've had some success with cohorting. But I never say it's impossible. I think it should be on the checklist. It should be in the playbook of things we contemplate, and how would we do this, and where would we move people? Where would staff take their breaks? I mean, you can think through it, but it's very, very difficult in our environment. It's
very difficult. Right. I agree with you, Josh. I'm not saying don't do it. And, you know, like I've seen places, and you probably have too, Josh, where you can look at the, you know, the structure of how it looks like, the plan of the facility, and say, you know, here's the cases, the reds, the greens, how can you look at it? I think it's turned out that if you're lucky and you have a community that has private rooms and separate wings and dedicated staff, that's where it's easier to cohort. So just saying, it's still good to do, because when you want to test, you want to have some kind of plan that comes from it. Now, the other thing is
if you're going to cohort, and again, I'm sure all of you on the call, this is obvious, but you've got to make sure it's obvious to the communities. Cohorting means truly separating everyone. I've had a number of communities that think, oh yeah, we have dedicated caregivers, but they forget about maintenance. They forget about housekeeping. They forget about dining. The staff need a separate entrance. The staff need a separate break room. You've really got to look at truly isolating those apartments from the rest of the building. And again, it's difficult. It should be considered, but it's often very difficult.
Yeah, and medical care, as far as medical resources go, you know, that's part of the, you know, the charm of assisted living, is that it doesn't have a lot of medical resources. The trouble is that when you have a pandemic, you need medical resources. So if you want to try to keep people there, you got to look at the things for COVID is you want to look to see if you have pulse oximetry and to see if you have oxygen. It's just something to keep in mind. And if you're doing a lot of monitoring and you're using what limited medical resources you have, it's probably better to prioritize to use them for somebody who would want to go to the hospital if they got sick versus somebody who's a do not hospitalize. So that's all. I just want to just talk about that briefly. So Dr. Wen, do we have any questions for this topic? You're muted.
No,
There you go.
but I actually have a question. I was wondering if it's difficult to cohort anybody. If you had to prioritize cohorting, would you say that you should cohort the dementia, the memory care unit?
Yeah, I think every operator who has a memory care unit, even if there's no COVID, should already be thinking about cohorting that memory care unit. They should already be isolating it from the rest of the community, both in terms of the staff who work in that unit, the staff who support the unit, so that if you have cases pop up on one side or the other, they're already separated. Memory care, not surprisingly, is the most difficult environment to deal with COVID because of the extreme difficulties in isolating the residents.
Which makes them high risk, right?
Yeah, once you have it pop up in memory care, there's a good chance you're going to have multiple residents become infected, if not the entire unit.
Exactly, right. Okay, next slide, please. So training and reporting. Now I'm going to go to the reporting first. All I'm going to say is that you're going to have mandatory reporting, but I've seen some places where the administrator gets overwhelmed because they don't have much of the staff. So if there's anybody who can take something off of the plate of the administrator, that's good. But training is the issue, and that's the PPE. And Josh, why don't you dive into that one?
Yeah, I mean, I think particularly PPE is probably the biggest training area we're seeing staff require, because again, most assisted living communities have rarely, if ever, used droplet precautions. Even when they are dealing with seasonal influenza outbreaks where they maybe should implement droplet precautions, they probably haven't in the past. You know, at the most, they've probably done masks, probably never N95 respirators. Certainly they haven't done fit testing of N95 respirators. And the idea of gowns and face shields and eye protection and the whole bit, it's a foreign and, you know, environment for most of these frontline staff. So again, to most of you, it's very rudimentary, but really training them on donning and doffing the PPE. What's the correct sequence? How do you take the PPE off without contaminating your hands? The importance of performing hand hygiene, even little things like you should set up PPE outside the apartment and a trash can on the inside of the apartment. So you can don it, go in, and then dispose of it before you leave the apartment. I've had to talk to a surprising number of communities that didn't even really have hand washing facilities in the apartments. You know, there's a bathroom in there that the resident uses, but what they have for hand washing is a common, you know, cloth towel. They don't have paper towel dispensers. And so simple little things like that are what is needed often in training. You know, of course, as you can imagine, we've trained staff on things like signs and symptoms and responding to a positive case, but it's really the basics of the PPE that is the most important training point.
The most important, because, you know, you talk to people and where these communities are getting COVID is from the staff, and they're getting from the staff because they're probably not doing the infection prevention and PPE correctly. I mean, it's hard, and every webinar you'll go to is going to say the same thing. You got to teach, reteach, you know, have people come in, try to do it early if you have an outbreak, reteach, have them practice, have them look at, you know, do in-services. You know, maybe that's the biggest thing I think about trying to prevent it in assisted living is continuous and repeated re-education about PPE. Mm-hmm. Okay, Dr. Wen, do we have any questions?
Yeah, we do. One a little unrelated, but behavioral health is another issue during this pandemic in a resident or assisted living, especially with those with dementia, even their families. How do you address it?
Yeah, we'll talk about that, taking care of the staff. We'll do that near the end, but of course, that's completely true. Go ahead. Yeah.
And the next one is, due to a lot of the restrictions we have in place, our assisted living residents have had to dramatically adjust their daily routines. As a result, there's less interaction with each other, with their families, and with staff, since we encourage good social distancing. We have noticed quite a bit more falls this month, and we're not sure of it. Is it directly related to the lockdown we have in place, having more falls?
Josh, I think we can both say yes.
Yeah, I assure you it's related to the lockdown. We in the communities where we track falls, we've seen increases in around 30% across the board in falls. The one thing I would say is, you know, we want to isolate the resident or restrict residents, I should say, to their apartments, but we don't want to ignore them. So we still need to be in there providing care. You need to find, as I'm sure many of you have, creative ways to do programming. And one thing we're seeing is this is emphasizing more than ever the importance of a good partnership with rehab. It's usually not that hard to get rehab into assisted living. They're usually banging down the door trying to get you to let them in. Obviously, right now would be under restrictions, and you would screen them and they would wear PPE. But we still have rehab coming into our communities to work with residents in their apartments. And I would encourage you to keep that going now. And I would encourage you to talk with your rehab partners about a post-COVID recovery plan. You know, what can they bring in terms of rehab and therapy to help our residents get back on track? Because there's no question, no pressure.
Absolutely, it's good. It's going to mess up. First, it's going to mess up your QAPI numbers, And just like in nursing homes, there's going to be so much deconditioning. Dr. Wen, was there a question?
Yes, yeah. Can you share techniques on keeping isolation protocols for cognitively impaired residents who might walk off his or her room?
See, yeah, I don't think there is one. And that's the problem. That's what we found out. That's why memory care units are such an issue. I don't, Josh, do you think anybody has an answer to that?
Well, I mean, none of these are answers, and there are things I'm sure many of you have tried. You know, increase the frequency of hand washing, try to demonstrate and get the resident to wear a mask. Sometimes we've had success with that. We've had a few instances where we've used one-on-one private duty to redirect the resident, where they're literally all day long just helping to redirect that resident away from others and back into their apartment. But at the end of the day, the only true isolation I've seen work in memory care is with residents who are in late stages of hospice or residents who are transfer dependent.
Yeah. Okay.
I'm just being mindful of time. There's 10 more minutes.
Right.
If there are really big pearls you want to highlight, you know, this is the time to do it. And if anybody
Absolutely.
has dying questions, you better type that in.
I'm with you, Dr. Wen. Next slide. So just look into ways to help staff. Some people put up staff in the community if they have rooms or hotels. Sometimes they've talked about sharing uniforms. Now, the thing with uniforms is that a lot of stuff they wear, you know, khakis, polos, disposable gowns are very uncomfortable. Scrubs might be better. But just want to look at ways to help staff. Josh, you have anything to add to that?
Just quickly, the lodging is really important. Staff, one of the most common things they're afraid of is not themselves, but their families. And whether it's an accurate fear or not isn't the point. It's a fear they have. And so if you're dealing with active COVID and you can find a way to lodge them either in the community or in hotels. I know, again, I'm not certain about Hawaii, but I know many states like California, for example, has a program set up with hotel operators that will allow healthcare workers, which includes us, to stay at close to free in a hotel room. So just look into anything you can secure with local hotels who right now are dealing with massive vacancies, and it would probably cut a pretty good deal to get your staff just a place to stay so they don't have to go back to their families until the COVID is resolved.
Right, absolutely. And the healthcare provider notification, this is one of the several advantages if you have a medical director, because, you know, they can assume responsibility for that. I mean, I have all their cell numbers, so I've been able to text them and call them, and, you know, or the community has sent out faxes. You know, it's just important to keep the doctors, I think, on top of things too. Any questions on that, Dr. Wen?
Nope.
Next. Advanced care discussions are really important, really, really, really important, particularly in dementia units. And all I'm going to say is that they are incredibly time consuming, you know, because it's somewhat easier in a nursing home which are sort of like hospitals. So when you say to them, well, the only real reason, if you don't want to be put on a respirator, be put on a ventilator, then there's a case to be made, perhaps you should stay in the nursing home. The problem is the assisted living community may not have the same, you know, number of medical care. You know, they don't have RNs there, they don't have intravenous. So it becomes a more involved discussion. And if you can possibly do it, sometimes you can't if you're in the midst of an outbreak, but that's really important to do. I think getting hospice on board is important, particularly, you know, because there's a 20, 30, 40% death rate. Some communities don't have relationships with hospice. One of the advantages of getting hospice is that they can bring oxygen in, which may not be available to the assisted living community otherwise. So it's important stuff. Josh, you want to add anything to that?
Just that I totally agree. You should engage your hospice partners now and ask them what their involvement would be and how they can work with you if you're dealing with COVID. It's, I think,
right.
Under-recognized.
Don't wait. Right. Okay, next slide, please. Here's family communication. This is so important. This is where the use of Zoom. Okay, you know, people are calling lawyers and they're reading the newspaper and things like that. It's just bad because everybody wants to blame, you know. So I think it's super important to And again, another of the advantages of the medical director. I'm just saying this flows naturally from this. I give a weekly call to both the families in the nursing home and in the assisted living. I know some nursing homes do it daily, and that's where Zoom is terrific. But I think bringing these things head on, being transparent, talking about what the numbers mean, because the families want to say, that they're equating like death with quality. So a home that has 8 deaths is better, than a home that has 20. Well, that's not necessarily so. But you can understand the family's frustration when they say, well, today we have 1 case, today we have 3 cases, tomorrow we're going to have, 10 cases. So there's this dread that something's going on and somebody's doing something wrong. So I think you got to tackle that head on. Josh?
The transparency, I think, is totally key. Let them know what's going on and keep them updated. In our communities, we send a minimum of a twice weekly update. Obviously more if there's changes that need to be communicated. When you have your first COVID case, the sequence I would recommend, other than obviously dealing with the medical attention for that person and isolating them, is talk to your health department so that you can understand what the health department's plan is, especially with regards to testing. I know we only kind of touched on testing, and you're going to dive into it more in an upcoming webinar. It will be the biggest question you get from families. Are you going to test everyone? When are you going to test everyone? Why aren't you testing everyone? It's where they're going to go. So ask the health department. And we're not telling the health department, we're asking them, do you think we should test everyone? Are you going to help us test anyone? What do you recommend with testing? So that when you go to make that first notification to your families, we have a COVID case, you can explain to them, you can be prepared to answer their questions, which I assure you will be about testing, will be at the top of their list. The second thing is just to be very transparent while still protecting people's information about what we're dealing with. Is it an employee? Is it a resident? Is it both? Et cetera.
Yeah. And what you do in Hawaii is really good. Maybe you don't want to ask the Department of Health, but you want to be collaborative with them. You want to be a team that works together. I think it's the ideal. So
yeah.
Next slide, please. All I'm going to say about resources, and we talked about PPE, is it really is information overload. So you want to try to get 1 or 2 good sources. I am not being unbiased here, but what Josh did is Josh puts out a COVID protocol that I don't know how I got on your email list about this, Josh. And I said, hey, Josh, can I share this with people? And he said, sure, which I think is wonderful. That's one of the good things that's come out of it, the collaboration. So there are resources for people like, why do we shouldn't all have to reinvent the wheel. Yeah. And I think now, when I first went through this, we didn't know anything. Like we didn't know where to get PPE. Now, when you have your resources and you have contacts with the county and the state and the hospitals, it's not nearly as hard, but that's what you want to do. You want to develop these contacts so when you have an emergency for whatever, staffing, testing, you have people to talk to. And it sounds like Hawaii is there. But I'm telling you, when we first started, we weren't, and I'm pretty sure there are places in the country that aren't. Josh, your take?
Yeah, and I hope it's okay to mention a website, but everything we've been doing with COVID has been shared on the California Assisted Living Association website. So there's a lot of great resources out there. I just happen to know that one has all of the stuff we've worked on. So I'll just, if it's okay, I'll put their website in the chat window.
Yeah, why don't you? Thank you, Josh.
No,
next. Oh, good. Thank you. See, all right. Next slide. And this is the thing, taking care of staff and taking care of the leadership team. It's the same issues in assisted living and nursing home. I equate it to burnout. The trouble is there's not one solution to burnout, and one solution doesn't works for one person but not for somebody else. So you just have to pay attention to it. You don't want your leadership team to be proud or be martyrs. It's just a really, really, the emotional strain is tremendous. I don't have there's a lot of things you can try, and probably there's an hour webinar to talk about all those different things. Josh, have you seen anything particular?
I think, sorry, my dog's barking. I do think it's interesting that I think early in the pandemic, there was, I don't know how to describe it, almost a little bit of an excitement. We're all in this, everyone was working 15-hour days and had no problem doing it. Well, now that's turned into 2.5 months of that, and people are really getting fatigued. They are getting burned out. They're getting overwhelmed. So again, it just goes back to the leadership piece, talking with your managers, your department heads. What kind of support do they need? Making sure people are getting days off, even when you're dealing with COVID. There's no magic here. It's just the simple stuff. Just got to make sure people are supported, because it's starting to really drag on for people, I think.
Yeah, and an issue we've seen too is people get PPE burnout, and they walk down the hallway with their mask underneath their nose, or they say, "Oh, I'm not wearing any. I don't need no stinking mask." That's a problem.
The chin mask is my favorite. If you see people
do you like that? Yeah.
with these masks like this, and it's like, just throw the.
But there have to be consequences to people who just flout the rules, because they're endangering people's lives. Just so. Next slide. Because I think so. Just things to think about. COVID shows up unusually. You need to develop the relationships, which Hawaii has done, and I hope to get things standardized. The bottom line is getting our voices, the long-term care experts, to talk to the people who are making the policies. And I think good things could potentially come from that. The hot topic, like Josh said, is reopening, but we'll talk about that later. So, and I think is that the last slide?
That is. Now, actually, I just want to say thank you very, very much. Before we close, I want to say that we actually have a poll for our listeners here, because we're actually trying to figure out whether or not getting CNE is going to be helpful in addition to CME and things like that. So I'm just going to put that up there for people to start answering while we're waiting. While I close up a little bit, and I just want to say, make sure in order to get your CME and your credits that fill out the evaluation forms. And
Dr. Wen, we talked about a lot of stuff. I hope this was helpful to the audience. If you could let us know, we try not to talk too fast and try to just get the pearls for you, but we try to make it different than a standard nursing home COVID talk. So yes. We really hope this helped people.
Yes, I think so. I noticed, I recognize some of the people on the line and from the assisted living communities, and I think it's been very, very helpful. So we
hope so. We're happy to try to help.
Yeah, and so I think it'll be great. I know Josh has done some amazing work with this, drafting up this reopening thing.
Yes, he has.
And we've shared it here, and we're having really hard discussions, good discussions. And we're trying to hash it out a little bit. So it would be really great to have you back again down the road. So I just want to let you know, next week, June the 3rd, we will be having COVID reporting and tracking logs, which is dry but critically important. And also the June 10th session is on COVID testing updates, where we'll talk about the pros and cons of universal testing, point prevalence, surveillance, and testing for clearance, and all those hard questions that I know everybody has. So thank you so much. And I see lots of really great feedback here for you guys, that this was extremely helpful, incredibly helpful, great presentation.
Well, thank you.
So you can give yourselves a pat on the back.
Yeah, well,
CNEs would be valuable here, as well as CMEs and social work. Okay.
Dr. Wen, thank you for inviting us. And Josh, thanks a ton, of course.
Thank you very, very much. We really appreciate all of your help. Thank you.
Thank you. Take care, everybody. Stay safe. Bye-bye.